Well, thank you very much for joining us. I see lots of people online. Appreciate that. Most, if not all, are on mute. If you're not on mute, we'd appreciate you muting your microphone while you're not speaking. If you're not sure, on the right corner of your name and box, there's three dots. If you click on that, you should be able to mute your own microphone. Welcome to a special fundraiser Webathon presentation and Q&A by Americans for Safe Access, we'll refer to as ASA going forward, and Association of Cannabinoid Specialists, we'll refer to as ACS. And we thank you for joining us. My name is James Winokur. I'm a board member of ACS, and I'm also the CEO of Berkshire Roots, a Massachusetts-based cannabis cultivator, manufacturer, and dispensary operator. I'm a medical patient in Massachusetts as well, and since 2014, I've been fascinated by the potential of cannabis for medicinal use and thrilled to see how far cannabis acceptance has come in the medical community, most states in the US, and so many countries around the world in the past 10 years. However, we have a long way to go to fully understand the plant, the application of cannabinoids and terpenes relative to ailments and conditions, and how cannabis as a medicine is prescribed, administered, and purchased. The missions of ASA and ACS are in lockstep, which is why we have partnered to bring you this event. Both organizations have actively pursued educating the general public, regulators, lawmakers, and healthcare professionals. ASA is focused on patients' rights and advocacy for ensuring the expansion of medical programs throughout the US. ACS is focused on educating healthcare providers through the curation of viable research and the experience actual clinical practices have taught us about patient care. I'd like to invite Debbie. Debbie, if you can unmute your mic. She is the executive director of ASA, and she'd like to say a few words about their program.
Can everyone hear me, first of all?
Yes.
Yay, okay. I was having troubles for a second. Hi, everyone. Thank you so much for being here. As James mentioned, I'm the executive director of Americans for Safe Access. And for those unfamiliar with ASA, we refer to ourselves as ASA. We are a national nonprofit patient advocacy organization. ASA was formed in 2002, so we're celebrating our 20th anniversary this year. We were created with the mission of helping to ensure safe, legal, and hopefully one day also affordable access to cannabis for therapeutic use and research. ASA is different than a lot of other organizations in this space in that our priority is on the patient and on the patient experience and viewing cannabis as a real medicine. We work towards expanding the scientific knowledge of cannabis while also helping to end the stigma and help create laws and programs that work for patients across the country. We believe everyone should have equal access to this medicine, no matter where you live in the country, what state you live in, or what condition you have. I just wanted to thank you all for being here tonight. Big thank you to all the doctors for being here tonight. We really rely on experts to help us talk to patients and understand the patient experience. So a big thank you to the doctors here tonight. And just as a reminder, ASA and the Association of Cannabinoid Specialists, ACS, we're both organizations that work on donations. And so in order to do the work, we do need sponsors and donors and funding to do the work that we do. So we appreciate any amounts. I mean that any amount. Someone donated $1 and I loved it. I love it. Any amount, we appreciate bigger amounts too, but any amount is really appreciated because, you know, as the industry gets bigger, you think that we get more support, but unfortunately that's not what we're seeing. So we do appreciate anything you can donate tonight. We have the donation link on the following slides I'll show you. And thank you for joining us. And we hope that we get all your burning answers, all your burning questions answered tonight.
Great, thank you, Debbie. Appreciate that. Carla Burr, if you look in the chat, just put a link to the donation site as well. So we appreciate that. Both of our organizations are appealing to you and others like you to support our missions that we hope leads to more acceptance of cannabis as treatment for a variety of illnesses in the advancement of laws and regulations that protect patients and physicians through establishing a more traditional medicinal experience with an actual prescription in health insurance subsidies. Imagine that. Hard to imagine, but that's our mission. You have a role to play, not only through your donations to our organizations, but as a voice to your local and state representatives, demanding and encouraging they educate themselves and treat cannabis medicine as you see other medicines being regulated. That's your mission. Tonight, you'll hear from 4 physician experts who base their opinions on research studies and their own clinical practice. While we acknowledge there's plenty of room for more research, there's also a lot of data available today that healthcare professionals can rely on. The objective tonight is to allow all of you the opportunity to ask the doctors anything related to cannabis that might help you decide to speak to a physician about your use of cannabis, sort out whether what you have read or heard is backed up by scientific research or not, or look a little deeper into an ailment or illness that you've been curious whether cannabis is the best or helpful treatment for you. So that's your opportunity tonight to ask these doctors. The 4 physicians who have joined us this evening represent a good cross-section of medical expertise. I'd like to introduce each of them, give a little background, and then we'll have each provide some more of their background as they go through the process with you in our next segment. So before I do, as we mentioned, this is a fundraiser, so you will see that link on slides. As I said, the link is also now in the chat. We really want to thank all those who have contributed to ASA and ACS already. During the next hour, you can reach our donation site by clicking on those links, or after this session, it will still be live for a bit. And you're certainly welcome to go to either website, ASA or ACS, to specifically learn more and donate to one of those specific organizations. For tonight's webathon, we're sharing in the work to get this done for you, and we're sharing in the donation, so we appreciate that. So let me please introduce you to the doctors. First, if you can see your screen, the founder and president of ACS, Dr. Jordan Tishler. Jordan, you can wave us. Dr. Tishler graduated from Harvard and Harvard Medical School. He practiced internal and emergency medicine at Boston's Brigham and Women's Hospital, as well as community health centers, including working with veterans. Based on those experiences and his own research into the endocannabinoid system, he founded a cannabis recommendation practice, InhaleMD, to help people find an alternative to traditional medicines. Dr. Tishler continues to teach within the Harvard Medical School program, and for today's event, Dr. Tishler will focus on mental health. So you'll hear more from him in a bit. Next, please welcome Dr. Julia Arnsten. Julia, if you can wave to the audience. Thank you. Dr. Arnsten is chief of the Division of General Internal Medicine and a professor of medicine, psychiatry, and behavioral sciences in epidemiology and population health. Dr. Arnsten is a graduate of the New York University School of Medicine and completed a Harvard Medical School research fellowship in 2002. She has practiced internal medicine at Bellevue Hospital, NYU Medical Center, and Massachusetts General Hospital. Dr. Arnsten is a general internist with a longstanding interest in behavioral medicine, including adherence in medication taking, nicotine dependence, and substance abuse. For today's event, Dr. Arnsten will focus on pain management. Thank you, doctor, for joining us. Our third MD is Dr. Bonni Goldstein. Hello, Bonni. There she is. Dr. Goldstein graduated from Rutgers College and Robert Wood Johnson Medical School at the University of Medicine and Dentistry of New Jersey. She completed her residency and was chief resident at Children's Hospital of Los Angeles. She has been a clinical instructor in pediatrics at USC School of Medicine, as well as a pediatric emergency medicine physician. Dr. Goldstein is a sought-after speaker for many cannabis conferences and was awarded 2017 Healthcare Professional of the Year by ASA. For today's event, Dr. Goldstein will focus on pediatrics. Our fourth speaker is Suraj Tandon. Suraj, if you could wave, please. There he is. Dr. Tandon practices in the Toronto, Canada area. He earned his Bachelor of Science from McMaster University and worked as a co-investigator assessing physical and mental health disparities among South Asian immigrants. He completed his medical degree and residency in internal medicine from the Frank H. Netter MD School of Medicine in Connecticut, and an additional chief residency year from the Hampton Veterans Affairs Medical Center in Eastern Virginia Medical School in Norfolk, Virginia. Additionally, he completed a hospice and palliative medicine fellowship at New York Presbyterian Queens Hospital, with additional pain medicine training at Memorial Sloan Kettering Cancer Center in New York City. In Canada, he currently practices as a medical cannabinoid consultant and is one of the clinical site investigator lead physicians at McMaster University in the Michael G. DeGroote Center for Medicinal Cannabis Research. For today's event, Dr. Tandon will focus on neurodegenerative diseases. Thank you, Doctor. Before we get started, I want to thank our partners at ASA for working with us to organize this event. Thank you to our audience for attending. I'm sure you all know from our guest bios, we are honored these physician experts have made time to participate in this event and provide all of you the opportunity to learn the real deal when it comes to medicine and cannabis. Your donation will be shared equally by ASA and ACS to help further our missions so we can continue to offer research-based information to our members and interested people everywhere. Again, you can go to the chat area to find our donation link or follow the URL on the screen. Our agenda includes all four of our doctors having those centers of excellence prepared for a little bit of presentation, but mostly Q&A. They'll take your questions in an open forum. So at the time you want to speak, please unmute yourself and then mute yourself back. We have Dr. Tishler, who's going to present at the beginning of this, a little bit of ACS and his background, I'm sure. And we really appreciate your time tonight. I would like to ask Dr. Tishler to unmute, and I think we are ready to go with the main part of our event tonight. Thank you.
Awesome. Thank you, James. And thank you everybody for coming this evening. It's very exciting to have you here, and we're all looking forward to answering as many questions as you guys can come up with. Now let's just see whether Zoom is going to behave and show my slides. The little bit of a presentation I want to give before we get into the questions section is really kind of the intersection of medicine and law and philosophy, and quite frankly stems from my experiences practicing in this area and seeing the ways in which our current regulation in the United States and in most other places as well really doesn't support patient care. It doesn't support patients, it doesn't support their healthcare providers, and really is a very short-sighted look at things from the industry's point of view. So I really want to talk about, why we need a more medical system. I'm going to skip this section because I think you've heard enough about me. This slide is here to remind us that cannabis in one form or another, meaning medical or recreational use, has become legal in almost all of this country. And the regulations that we have adopted, which are largely based on regulations that were developed in the middle 1990s in California, are really quite out of date. And as I've mentioned, not supportive of the mission here. And most importantly, we've got this patchwork in front of us that defies any kind of national unified approach. This is really what I was talking about when I said that this is based on my experience taking care of folks. These are the things that my patients have come back to me and said, well, this is what happened to me when I went to the dispensary. And people said things like, I don't know what your doctor is talking about. Don't listen to him. I'll tell you what to do. This was from the bud tender. Come back controls. They kept trying to get me to buy more. They have volume deals and push other products. And what's up with the prize wheel? This isn't the Price is Right. He told me to add this keef stuff to my vaporizer, and now I feel sick, doctor. Why? All of this, come on. You were right, doctor. They immediately suggested CBD. It's a good thing you warned me about how dangerous this could be for me. Speaking specifically about a patient who was taking an important medication with which CBD could interact. The problem here is that the current dispensing system is really good for the industry. It allows them to use all sorts of upsell tactics, make claims without substantiation, and employ a lot of misdirection focused on the patient at the point of sale. And one of the things that really bugs me about this is the fact that in more conventional medication, in the pharmacy system, we don't have this problem because they're strictly regulated at the federal level. And it is very clearly defined who in the pharmacy system can say what about medications or give advice to patients. And the real problem is that bud tenders have inadequate medical knowledge, and without going to medical or nurse practitioner school, they're never going to rise to that level. And furthermore, we have to remember that the bud tender's primary role in life is a salesperson, which means that there's fundamentally conflict of interest between their needing to sell things and what is necessarily in the interest of the patient. We have to acknowledge, and this is something that is really important, that patients are not the same as recreational users, and often their goals are very much the opposite. I'm sure I'm preaching to the choir here. With recreational users, and I don't mean in any way to denigrate their experience or the validity of what they're interested in, but they're interested primarily in the intoxication and sort of the ride that takes them on, which leads them to be interested in new products. What's new and exciting? They're interested in experimentation because that's part of the fun. And generally speaking, though this is a generalization, more is better, right? The more cannabis you use, the more interesting and potentially enjoyable that may be. On the other hand, and again, I realize I'm preaching to the choir here, but patients just want to feel normal. They want to undo the harms that have happened from their condition. They want to get back to themselves. The high or intoxication that the recreational folks are looking for is really a side effect in the medical context. And quite frankly, most of my patients say they would like to avoid this entirely, which leads us to this concept of looking for the minimum effective dose. How little can we use to get the benefit? Not how much can we use, but really how little can we use? And often we have patients with multiple complex medical problems so that they might be going into the dispensary, for example, for something to treat back pain, but it may be in the context of something much more broad and complicated, like having had a liver transplant. So we need to understand that simple cookie cutter sales oriented advice at the point of sales is not only not helpful, but it's potentially harmful. As you guys are all aware, there are many cannabis bills right now between the House and the Senate. In the House, we have the MORE Act, which has been passed 3 times but never been taken up in the Senate, and focuses solely on business and racial justice issues. There's absolutely no mention of patient care. There's no actual regulatory framework. And quite frankly, I think that this particular bill is much more about saying that they support cannabis and not so much about actually supporting it. On the Senate side, there's the Cannabis Administration and Opportunity Act, which is Senator Schumer's re-election bid. And similarly, it's extraordinarily business-friendly, social justice-oriented. Certainly, we support the efforts for social justice, but we also have to remember that healthcare written broadly is a social justice issue, and these bills simply don't address anything having to do with taking care of patients. Healthcare, as I said, is a social justice issue. So what do we think that a federal medical system should provide, and sort of how we should factor this in to these broader legalization bills? Well, we feel that, to avoid some of this upsell and misinformation, we really need to get to a point where we can write a prescription that is honored by this dispensing system. Similarly, we need to have a little bit more control over who's saying what about what cannabis can do. We need to have interstate interoperability so that a patient from my area in Boston, Massachusetts, who winters in Florida can take their medicine with them, can get refills in Florida, and essentially cannabis behaves just like any other medication. We need common safety standards. We need greater clinical discretion, which is a way of saying we don't need these state-by-state lists of what can or can't be treated with medical cannabis. The healthcare providers should know that. We need systems that provide feedback on what is being sold. And we need to acknowledge where cannabis in the recreational arena overlaps with medical, and we need to have regulatory structures around making sure that everybody is getting what they need. And then, of course, we support a broad research agenda and would like to see more money fed into that kind of research system. So that's kind of our platform, the Association of Cannabinoid Specialists. We aim to increase the standard of care for patients, make sure that they're getting what they need, educate clinicians broadly about what cannabis can do and how to refer and when to refer to cannabis specialists. We provide education for those specialists. We wish to work with dispensaries and product manufacturers to make them operate better for patient care. We encourage research, and we want to improve law and regulation around all of this. So if you have questions or want to know more about us specifically, you can go to cannaspecialist.org. You can always email me directly at president@cannaspecialist.org. And I very much appreciate your listening to me enumerate the problems and potential solutions that we're facing at this time. That's really what I wanted to bend your ears about. And now we can get on to the part where we answer questions. And I'm sorry, I'm trying desperately to find the button to put the slides away.
So while we're putting the slides away, we introduce you to the four physicians. You just heard from Dr. Tishler. We mentioned the four primary areas. They're all four certainly capable of answering other questions. We'd love to have that form for you to ask questions. You have to unmute yourself to do that. You can use the tools in Zoom to raise your hand if you're not sure, how to get someone's attention other than speaking. And for our four doctors, if there's anything you'd like to preface this section with regarding your own background or statement about your specialty, you certainly can unmute yourself and provide the audience some of that material as well.
So Jordan, Dr. Tishler showed you that the map is patchwork, and we all come from different states, so and countries. And so that really influences how we're able to practice. So in New York State, I have a certain way of practicing. New York State has recently changed its law regarding adult use cannabis, but we don't have any dispensaries. We only have medical dispensaries, and I practice in a very particular way that is highly medicalized. As a result of that, and as a result of my position in the university, I've been able to really normalize medical cannabis for many generations of training doctors. But my particular focus clinically is adults, and I see a lot of adults with chronic pain. In our practice, those adults also have many other medical conditions as well. And we're doing our best to help take care of them. So that's my introduction.
Suraj.
Hi, everyone. I'm happy to be here, and it's very nice to see many faces. Just to add on, thank you, James, for the wonderful introduction. Aside from working here in Toronto, we're certainly much different than the United States and New York, where it is a bit of the Wild West here. Sometimes we need to sort of pump the brakes a bit in terms of educating patients and providers about safe access to cannabis. So aside from working in the private setting, doing medical cannabis assessments, I work now at University of Toronto, primarily within the inpatient setting in the hospice and palliative department. So we are certainly changing reform as much as things are legal here in Canada from both medical and recreational perspective. There's still a there's a lag in terms of policy development, especially at the institutional level. So my interests are primarily in the medical cannabinoid assessment space, but also in the hospice and palliative discipline as well. So very happy to answer any questions. And I would encourage each of you all to ask questions. And I think making it in this sort of format where sort of a roundtable discussion might be a bit more entertaining. And this way you get opinions and sort of input from various providers with different backgrounds. So certainly welcome you all, and please ask questions.
Bonni.
We already do have a few questions, so whenever you guys are ready, I can ask some questions, and feel free to message me privately with some questions. Some people have done that as well, and I'm fine to read them for you.
Yeah, I see there's a question about nursing mothers, and I don't think any of us have a particular background in OBGYN, but I can say that my general approach to women who are pregnant or nursing is to see if they're using cannabis that they're buying from the unregulated market. And if they are, then there's a safer alternative to that. And if they're really not, they want to try cannabis for a particular symptom, then we're kind of in a data-free zone. We know that regular chronic use of inhaled cannabis is very weakly associated with lower birth weights. And that's about what we know in terms of really knowing it. And so this is really an individual discussion with each patient about what their experience has been and what kind of risks they're willing to take. I don't think there's a yes or no, but I'm really interested in what the other docs think.
I think it's a very interesting point you brought up. I completely agree with your assessment of the data or lack thereof. I tend to err on the side of perhaps greater conservatism, which is funny for me. I don't think of myself as particularly conservative, but I take a position which was mirrored by ACOG, which is the American College of Obstetrics and Gynecology, which is essentially, given the fact that we really don't have any good long-term data here, my advice and their advice is to abstain during pregnancy and breastfeeding. And so, I have lots of young women in my practice. We discuss these things up front, and typically I say, look, if you're planning to become pregnant, we want to get you weaned off cannabis medicine roughly about 3 months ahead of time. And if one becomes pregnant unexpectedly and is planning to carry to term, then one should stop the medicine thereabout. And there are other alternatives, albeit maybe not as good, but there are other alternatives that have a longer safety track record. So that's my take on that.
I have another question from someone, unless anyone else wants to add to that.
I was going to just add to what the other two physicians said. I certainly agree with their sort of proposition on cannabis and pregnancy or breastfeeding, or in terms of conception. Certainly, I think it's always better to be safe. There is, though there's, data that's coming out to show that, as Dr. Arnsten mentioned about in terms of fetal birth weight. Typically I've had a number of patients in my practice ask about, utilizing cannabis during pregnancy or breastfeeding. Certainly, again, I advise against it. And really, or if the need be, is to look at alternatives or consider its use after breastfeeding is completed, or, in terms of the patient delivering their baby. We know that, in terms of childhood development, here in Canada, there's a strong recommendation against utilizing cannabis in individuals under the age of 25. And that's really for the reason that the brain is not fully developed until that point. So using it in individuals who are, breastfeeding or planning to conceive, increases the risk of developing some of those mental health diseases later on. So again, best to avoid at all possible.
I have a question someone sent me. I have a PK question. Would an intranasal delivery of cannabis still have the potential to impact serum levels of an orally administered drug that is known to compete with cannabinoids during FPM in the liver? If so, could it be enough to raise liver enzymes?
I think the short answer to that is yes. The thing about intranasal absorption, buccal absorption, or frankly, any of these forms of absorption, with the exception of oral ingestion, is that we're essentially introducing delta-9 THC and everything that goes with that directly into the bloodstream. When we start talking about oral, we're talking about first pass metabolism, which means these medicines are absorbed in the gut and then the first stop is the liver, where the majority of that delta-9 is changed into 11-hydroxy-THC. We think of this as what's called a prodrug, meaning what you take and what treats you are different, and the metabolism is involved in the creation of the medicine that we're actually interested in using. That being said, the processing of different cannabinoids is done by different enzymes in the liver. And so to really address the question that you're asking, we have to ask which medications we're talking about, both on the conventional side, as well as which cannabinoids we're delivering by whatever the route is. Hopefully that helps. It's not a very specific answer.
We are getting a lot of great questions, and I'm putting all your questions on a sheet, so we'll get to them all one by one. So does anybody have anything else to add to that before I move on to the next one? Okay. So the next question is, I'm a semi-retired cannabis physician in Panama. Although Panama passed an MMJ law last year, it still hasn't been implemented. My main interest is in educating physicians down here regarding the use of CBD for seizures, especially in children. Are there any seizure disorders that you have found CBD is not very effective in treating?
That sounds like a question for Bonni.
Yeah, I can address that. So the simple answer is no, I have not found any seizure disorders. I think it's more than just what type of seizure disorder children have. And by the way, I will tell you that I have patients who have intractable seizures who, along the course of their treatment, have sought out numerous different neurologists, and even the neurologist can't decide on what the child has. For instance, there's a little boy I'm taking care of with Lennox-Gastaut syndrome, which is a particular type of syndrome based on the EEG, and yet 5 different doctors, 3 say yes and 2 say no. So the question of diagnosis is sometimes a little funny. And so the key, of course, is to make sure a child has at least a proper workup and has, and that's the hardest thing, is getting the best diagnosis. But anyway, the one seizure disorder that I can say is absence seizures. I have seen a reduction, but I'm not blown away like I am with the seizure, the other type of seizure disorders. So absence seizures may or may not respond. I have had patients who have, but my overall take on it is that we don't see such great results compared to other type of seizure disorders.
Does anybody else want to add anything to that? Thank you, Dr. Goldstein. Okay. Our next question is, if only 10% of medical schools cover the endocannabinoid system, how do you propose closing that knowledge gap to create canna-aware clinicians who are recommending medical cannabis? Question for anyone.
So I'm happy to take a comment on, then I'll let Jordan chime in as well. So this is something that resonates with me, is sort of as a fairly recent graduate and fellow and learner, having gone through medical school, residency, fellowship, particularly in hospice and palliative med. There is a substantial gap in having appropriate or evidence-based knowledge or a curriculum available to learners, especially in the medical school setting. I think as you progress, we're seeing this sort of evolution and understanding and acceptance and destigmatization of cannabis and its its efficacy, where that I was fortunate enough in medical school or residency to have some exposure by working with various types of specialists, palliative care doctors, oncologists. Again, it was very limited. Moving into fellowship, again, we've seen a huge jump in the acceptance of it, but again, there's a large learning curve. There is a need of buy-in by all providers, including institutions, academic institutions, and physicians, and still many providers still have a bias against it. So one of the things that I'm doing, and Jordan's certainly heavily involved in making great strides at educating not just providers, the public, but also the institution, teachers, and incorporating various types of curricula into these types of programs, whether it be starting in medical school, residency, and fellowship. We have a long way to go, but I think that's something that we need to continue to do. That's just my comment regarding, I think, 10% of medical schools certainly are covering or not covering. To the second part, I think, how do you propose closing the knowledge gap to create Canada work? I think we just need to, again, continue to advocate, educate our not just patients, but providers, politicians, and to really show that this is necessary, because patients are asking questions. Being here in Canada, I would say 90% of providers have a real, don't really know how to prescribe or are prescribing incorrectly or unsafely. And that's what we don't want. We want to ensure that, people are being educated, taught, and to ensure that patients are being treated safely. So we need to continue to educate the public, especially providers, and really by doing, by getting the buy-in is furthering the evidence by producing higher quality studies.
Amen. I will tell you that I have been after my home institution, that's Harvard Medical School, for 5 years now, to allow me to teach this in a course. Initially, I tried to get them to let me to teach the medical students. They weren't interested in that particularly. So I host residents in my practice on a regular basis, and I'm finally now getting to do a CME course aimed at general healthcare providers that should be out sometime in the next winter. So I think, I hope that lots and lots of docs will sign up for that, nurse practitioners as well. And that's, I think, one of the ways we're going to get around this this roadblock at the medical school level. I think that 10% is actually probably a larger number than I would guess. But I think we're moving in the right direction, and it's simply going to take some time.
If I could make one more comment, I think for the listeners who are on here coming from various backgrounds, I would urge you to reach out to your local senators or here in Canada, or MPs or MPPs. We've been fortunate here in Canada to have some significant strides at the academic and institutional level to allow learners to have education regarding this. But for the listeners who are here, we need your support to really work with your local community, your institutions, academic institutions, and certainly, being part of ACS, our mandate is that we look at this from an evidence perspective, evidence-based perspective, where any sort of information, advice, recommendations, or resources are certainly all evidence-based. And we have a number of providers from a wide array of backgrounds, not just physicians, nurses, but we have scientists, clinicians, and people involved in the entrepreneurial side, but even at the policy level. So I would just encourage you guys to reach out and certainly come to ACS for additional assistance if need be.
Let me add one other thing there. I think, we as physicians are forever learning from our patients, both what our patients tell us and what their experience has been. And, cannabis is, of course, in that vein. When you sit down with your doctors, you may be worried that they will look at you funny or whatever. I have to say that my experience has been with my colleagues has not really been that heavily stigmatized or negative. But I think one of the things I would say to you guys is, there's some degree to which you don't necessarily really want to argue the point to your doctor, but you can certainly say to them, look, here is the Association of Cannabinoid Specialists. They have countless evidence-based research available to you, doctor, and coursework available to you so that you don't have to take my word for it as a patient. You can take the word from your colleagues and from the research science. So here is a resource if you can avail yourself of it. And I think that helped you interact with your doctors in a way that points them to the right information without your having to sort of beat them over the head with it.
Love it. Thank you. And a great question as well. I'm going to move on to the next question because we're getting a lot of them. What do you typically recommend for your patients with IBS? Is there any validity behind the claim that CBG is good for digestive disorders?
Oh, I typically recommend to IBS patients a THC dominant regimen in very low doses. There's good evidence, not so much for IBS, but good evidence from IBD, Crohn's, and ulcerative colitis that cannabis, THC again, is helpful for improving quality of life. And certainly in IBS, quality of life is sort of the primary mission. As for CBG, there's really not enough evidence to make that kind of a statement or to make recommendations. There's some beginnings of preclinical work, which means work that's not yet done in human beings, typically a mouse or a cell culture, AKA test tube. And some of that stuff is starting to look very promising. There was a great study that was actually published just yesterday from Hawaii. And I think it's a game changer, but it's not done in human beings. It's done in a test tube. So I think that we've got, particularly on the West Coast, a whole raft of cannabinoids that are freely available to purchase and to use, where there simply isn't enough evidence at this point to merit using them. And hopefully the science will catch up soon enough that we can start to make some really intelligent recommendations.
Can I chime in on that, Jordan?
Please.
So I have a handful of pediatric patients that have been diagnosed with IBD, not IBS, but we're talking about inflammatory bowel disease, and children who even have had parts of their colon or their entire colon removed. And many of them continue to have ongoing issues. Not all of them have had the colectomy, but my recent experience using CBDA, and the way that I approach almost all of my patients when we don't have a lot of data is to, of course, under medical supervision and proper dosing guidelines that I give to patients, I kind of go through the various cannabinoids that are available because not everybody responds to CBD or THC. And so I have been using a lot of the more minor cannabinoids like CBG, CBDA, THCA, and CBC, cannabichromene, which is now available. And there is some evidence from the animal data to say CBC may be a nice compound for the gut. Again, lacking research. So certainly human clinical trials we do not have, but I have seen some nice results with CBDA, which is, remember, the raw form of CBD. It is non-intoxicating. You can elevate dosing fairly high with no negative side effects. And I have seen it come as tinctures. I've seen it come as capsules. Of course, you always want to make sure that your product is safe, tested and consistent from batch to batch. But for some of my patients with significant gut inflammation, where we're actually measuring in lab tests or stool testing, it was CBDA that I saw reduce those inflammatory markers. So there is definitely a signal there that I would love to see pursued in research. And again, with CBDA, you can escalate dosing without really any fear of being intoxicated. And of course, in children that I'm expecting to go to school, that's certainly something that we're concerned with.
I have to send you this study. I think you'll find it fascinating. But anyway, I digress.
The only other comment I would add to is just from a personal experience, having treated patients with UC and Crohn's. Typically here in Canada, there's a wide variety of formulations and routes of delivery. Typically, we use oils or capsules that contain oils. What I found in terms of feedback from patients suffering from this, irrespective of the type of cannabinoid concentration used, is that the oil sometimes will worsen some of these IBD-related symptoms. And so one of the approaches that I found to be quite effective is using milled cannabis. So we have access to milled cannabis, which is encapsulated in a capsule and still provides a sort of a similar relief. So something else just to think, again, data is, we need further data to substantiate these, especially in these sort of N of 1 cases.
It's also important for us to understand that these acidic forms, whether we're talking about THCA, CBDA, et cetera, are not very stable, right? And so they can degrade from the acidic form into the non-acidic form very quickly and under sort of what would be considered kind of normal storage conditions. I was recently trying to do a study in which we were going to look at THCA, and the problem was that many of the studies that look at the time course or half-life of THCA show that it can degrade to 50% in a matter of hours. I know that there are a number of groups out there, including Dr. Meshulam's group, who are looking at ways to stabilize these acidic molecules. But at the moment, I think we have to be a little bit concerned that something that you get off the shelf that may be CBDA on the label may in fact be mostly CBD and may behave differently from what we're anticipating.
And I'll just chime in. I've done some testing of products over time. Just because of that situation. And what I found is that the data that we're basing all that on is a little bit old, maybe more for THCA than CBDA. My patients what I have them do is drop their dosing very quickly and keep everything in the refrigerator so that they're not taking the bottle out and putting it back and taking it out and putting it back. Just drop the dosing, keep it all in the fridge to try to minimize. And of course, I also encourage them to wrap it so that there is no light as well, because like you said, it can degrade. But what's interesting is I have not seen over time with parents using the same bottle a loss of effect. So I don't know how we can explain that. Right. Is it that the inflammation's already, like we got to a point where the inflammation's down and now it's just easier to maintain than to treat? It's hard to know.
So many good questions and things for us to research, right? I just want to take a brief moment to see, there was somebody who asked a question related to this in happened to be, I'm staring at it, says, CBDA can be gotten from CBD tea, correct? And actually that's not correct, because the problem is once you heat up the cannabis, the CBDA is going to degrade into CBD. So you want to avoid heat. And then we can also get into the discussion of the fact that all cannabinoids hate water. And of course, tea and coffee and soda are all water. And so putting cannabinoids into a water-based solution creates a whole raft of other problems. But I just wanted to sort of sneak that in there since it was staring me in the face.
Thank you. We're going to move on to the next question. What is the research on the interactions between cannabis and statins? It's one of the class of meds that are heavily prescribed. This person says a lot of people come into the dispensary for various reasons who also take statins and want to know the interaction.
Oh, let me answer that because I treat a lot of adults with coronary artery disease. And the role of cannabis in cardiac patients, or the interactions between cannabis and cardiac medications, have been the subject of a lot of research. And what we know so far is that THC is associated with an elevated heart rate. And this has led to, in many states, laws that suggest that coronary artery disease is a contraindication to using THC. That's what I have in New York. So all of that being said, statins, it depends on why someone is using the statin. So if I believe that somebody is really at risk for their heart rate being elevated for any reason, I'm going to suggest low THC, high CBD formulations. And perhaps increase the THC over time. But if somebody has very stable heart disease and is taking a statin for that, or they're taking a statin preventatively, I don't think those cardiac side effects are something to worry about. Now, is there a drug-drug interaction because of metabolism through the liver and the same enzymes being used to metabolize both drugs? Perhaps. And that could be experienced by different people differently. So each person ends up becoming their own experiment. Do I feel more effect or less effect, or no difference depending on when I've taken the statin? Jordan, it sounds like you had some experience with this as well. So you could
I think everything you said is spot on. I have a whole lot of patients who have pretty severe cardiac disease. As Dr. Arnsten said, a very common reaction to THC is elevated heart rate. If you have narrowed coronary arteries in your heart rate may get up high enough that you're not getting enough blood supply to the heart, and you can have a heart attack simply on the basis of your heart's need for oxygen outstripping its supply. That's not very common, thankfully. But there are other cardiac issues that we need to be aware of. THC can stimulate an aberrant or an abnormal cardiac rhythm called atrial fibrillation. Generally speaking, it's not a big deal, but it can be for some patients depending on sort of their baseline. And we also know that THC generally decreases the strength with which the heart contracts. And again, in somebody with a normal heart, that's a non-issue. But if somebody is already coming in with a severely damaged heart who might have, only sort of 15% of the squeeze, then, we have to be really careful about that. On the other hand, anybody who's approaching me with those kinds of baseline problems also has severe something else, pain usually. And so that's a risk-benefit analysis between me and the patient, and often I loop in their cardiologist so that we're all on the same page. And by and large, generally, if people are in that much pain, they're willing to take on a certain amount of potential risk to see if this will help them. The statins in particular can be affected metabolically by CBD, not so much by THC. So again, that's something that one has to think about in the prescribing process.
Can I make a comment about the, I know I'm a pediatrician and we don't really see heart stuff too much, but I would just like to say in my experience overall doing this now for almost 15 years, when I look at the scientific literature where they do talk about a slight increased risk of cardiac problems. We're talking about, and when you look in the literature, it is very rarely somebody who is under medical supervision. So let's be very clear about that. It's usually somebody who is using cannabis, maybe medically, but not being supervised, and may not know everything that they need to know because they haven't consulted with somebody who has studied about the endocannabinoid system or studied about these various cannabinoids and understands the receptors, where they work, and the other mechanisms of action. So when you read, there was an article that came out a few years ago called The Good, the Bad, and the Ugly. I'm sure you all have seen that article about basically how cannabinoids may affect the heart and the cardiovascular system. And when you look at the data, it's mostly people who overdid THC and ended up in an ER almost as a case report, and kind of put themselves at risk because of what I call unopposed too much THC. And so that is not what most cannabis physicians are doing. We are taking into account all of the risk factors and trying to come up with the best plan of action to minimize the effect and minimize any negative effects. And what Jordan talked about in his slideshow, which was minimal effective dose, which very rarely causes issues. If you, in my experience, I just don't see a lot of issues when someone is being medically supervised. So for anybody out there who has an elderly parent, like I have a 92-year-old father with coronary artery disease. He does take cannabis medicine, but his total amount of THC is a very low, and all the other cannabinoids are very high to help with neurodegenerative disorders and all the other things that go along with being old, and just no issues, right? And again, it's part of a whole plan that's based on, the patient's medical history.
Many of the studies that have looked at the incidence or the increased risk of the heart attack in particular are, what we call a retrospective chart biopsy, which essentially is somebody is going into the computer in a hospital system or some other database and looking for heart disease and positive THC test, which is a classic association. These two things did exist at the same time, but then there's an attempt to infer causality that the THC caused this heart attack, and that it's plausible, but it's not really considered acceptable scientific logic.
Okay, we're gonna switch gears here for a moment and ask a question about, this is a good one. I would like to know about replacing antidepressants and anxiety meds with CBD.
Yeah, probably not going to happen. Again, the evidence for CBD in human beings is pretty much non-existent. There are some studies that look at things like stage fright using doses of about 300 milligrams of CBD, and that was in fact a positive study. There have been some more recent studies that have been looking at CBD for anxiety and depression that have failed to show benefit. Many of which, in fact, have not been published, but I have been privy to their data set. On the other hand, there is some not super great evidence that using low dose THC can be effective, but it comes with a big caveat that it has to be used, like Dr. Goldstein was saying, in a very conservative and guided fashion, and that the sort of typical, shall we say, cannabis aficionado approach of wake and bake, it has clearly been demonstrated to be counterproductive, both in terms of school and work productivity drops, as well as increases in actual anxiety symptoms. So my typical approach would be a low dose, sort of typically, 5 to 15 milligrams delivered either by inhalation or by oral, given in the evening or at bedtime, but not during the day.
I'd like to chime in, just clinical experience treating teenagers with anxiety and depression. And many of them have tried THC to an extreme and come into the office where the parents say, I definitely see benefits, but it's like too much THC and we're starting to lose medicinal effects because of tolerance. So many of these patients, I have found a combination of CBD and CBG to be beneficial for daytime dosing. I start low and go slow, 10 milligrams of each, or you can try CBG by itself or CBD by itself, and then titrating up to see how you feel. And one of the things I do with teenagers, because as we all know, they're very difficult when you're trying to get information out of them, is to create like a little Excel spreadsheet or just a handwritten to rate how they feel. And what I have them do is put dates down one side and their symptoms. So anxiety, sleep, depression, mood, appetite, functionality. And I ask them to rate on a scale. I talk to them about how they, 5 being I had a great day and 1 being it was miserable day. And what's interesting is that over weeks of using CBD, CBG, many of them, you'll start to see those numbers go from low to better, higher numbers. And, but and the parents witness it, but the child still may be kind of stuck a little bit, or the teenager might be a little stuck. But I think for adults as well, I do have still some adult patients in my practice who I've taken care of for many years, who have switched from THC-based regimens to now adding in CBG and saying it has helped quite a bit with anxiety. And I don't know that there's any evidence right now. I haven't seen anything on other than a recent report that Dr. Russo, Ethan Russo, who everybody knows, they did a survey, which is not what we would call a randomized controlled trial, but it is a survey of CBG, and the perception of how it is benefiting in anxiety and depression were rated fairly high in that survey.
I think this is really a very interesting place where we are historically, right? I mean, we've got access to all of these chemicals as medicines and just not enough information to be able to make really informed decisions. Thankfully, as Dr. Goldstein points out, to the best of our knowledge, most of these cannabinoids are relatively safe. And so there's a certain leeway to try things out. One of the studies that I was alluding to earlier, we did in fact a randomized controlled trial of CBD versus placebo. And what was really interesting about the outcome was that placebo generated a 71% reduction in anxiety. However, the CBD did not do better. So we can say that there were probably some study issues involved in the way in which the patients were biased by the questions, but ultimately there was a huge placebo effect and no additional benefit from the CBD. Unfortunately, the company that's sponsoring that doesn't want to publish it, but despite my urging. And so there's all kinds of stuff that's going on in the background in terms of the science, and hopefully at some point we're going to get more concrete answers.
Is there anything regarding the use for THC with anxiety as well? We kind of focus a lot on CBD, but what about THC?
There is, and there's lots of information, but you have to be very moderate in your use. If you escalate your use and create tolerance, you lose. So what happens is your cannabinoid receptors migrate into the cell if you overdo, and then they're no longer available for the THC to bind to. So you end up escalating your dose, and you're basically taking away the target of not only the THC, but your own natural endocannabinoids. And we don't want to do that. So clearly, and there's lots of studies that show this, low intermittent use, as Jordan mentioned, with, using in the evening, low doses. But certainly too, you can use CBD and THC together. The studies on Sativex, which is a pharmaceutical mixture of 1-to-1 ratio CBD to THC, show that tolerance, there's lots of studies on Sativex, tolerance doesn't develop. So including some CBD in your mix is not a bad idea, and it will help mitigate some of that development of tolerance and allow you maybe to benefit from both of those compounds. But ultimately, and I talk about this whenever I'm trying to help people manage their medication, is unfortunately right now, the best we can do is trial and error. but you have to be methodical in your approach. So many people start with high CBD, low THC, maybe lower the ratios, and then start to look at CBG and CBDA and THCA kind of in that fashion. One thing we know is that, again, under medical supervision with someone helping you, these are very, very safe, because we're not interested in harming anybody with these compounds. Those of us who work in this field, we've seen the harm in kind of the other side when, we left the pharmaceutical model, and we've seen that harm. But I think that we have to remember that it is very helpful to have a clinician guiding you, because that experience, instead of the N of one, we have N of many. And maybe it's an N of one multiple times, that we've seen, and we have a little tricks to what we do and how we handle this. But certainly I would include THC, just not all THC all the time.
I wanted to jump back in. I'm noticing some questions coming through about tolerance breaks in the context of our discussion. This is just my take on it. Tolerance breaks are a very effective way of resetting your tolerance. Dr. Goldstein spoke about how when you flood the CB receptors with THC, the cells respond to that excess by removing the receptors, and then you don't have enough receptors for your endocannabinoids. If you stop flooding the system, then they'll say, wait a minute, I don't hear any more THC, so they'll start poking those receptors back into place. So that's very effective on the recreational side. However, when we think about patients who have some sort of a chronic non-remitting problem, it's kind of not very kind of us to say, yeah, by the way, every few months you got to stop for a month or 2 weeks. It's just not a viable approach to medicine. So my approach has been, look, if we can keep the dose down to begin with and find that minimal effective dose, we don't see that escalation of tolerance to begin with, and we don't really need to get into a reset phase.
Okay, let me ask another question. This is another interesting one. This person says, I take 1/16 of a teaspoon of leaf and bud orally, and she or he finds that their body temperature increases, no fever, but with an oral digital thermometer, a noticeable increase in body heat. Why does that happen?
It's interesting for a number of reasons. We know that people who take THC can have some hypothalamically driven dysregulation of their core temperature. Usually they report being cold, and I don't know that people have really systematically measured core temperature. So I'm not entirely sure why you'd feel hot. The other thing is, if you're taking dried cannabis orally without decarboxylating it in an oven first, then you're getting almost entirely acidic forms, including THCA, but not THC. So I'm not sure I can give you a better explanation than that at all, because I'd be surprised at this phenomenon.
One thing I might add is that I recently did a deep dive into cannabinoid hyperemesis syndrome. And this is when it's usually very high doses of THC and someone develops severe abdominal pain, nausea, vomiting. It's a whole nother topic, which we don't need to focus on. But they appear to have this compulsive bathing in hot water that makes them feel better. And I read a recent report that says that there is potentially, this is coming from THC targeting what we call the TRP receptors, the transient receptor potential cation family. It's kind of very complex receptor science, but that it's not actually through the endocannabinoid system, but more through these TRP receptors, because the TRP receptors are also known as the capsaicin or the heat receptors. And so that might be where that's at. And I think everybody has kind of their own level. Interestingly, I did have a patient who, a little child with brain tumor, and we were trying to save her. So she was on pretty high doses of CBD and THC, and she started to have some issues with thermoregulation. So I don't think it's rare, but I don't think it's unheard of.
Okay, I'll move on to the next question. So many questions.
That's good.
What are your general recommendations for patients using CBD or THC for cancer and tumor regression? Can anyone answer that?
I'll take a stab. It's very controversial. And certainly I am not in the school of thought where someone should avoid what conventional treatment has to offer. If you have cancer, stage 3, stage 4, you should throw everything you can at that cancer. There is some evidence, again, there's very few human clinical trials, only 2 that I can think of, but there's a ton of preclinical animal data showing that cannabinoids are anti-cancer, anti-proliferative, anti-metastatic, anti-angiogenic, all these different ways that they can kill cancer. Also, we know that there's some evidence of synergy between certain chemotherapies and cannabinoids. There is also a few reports on cannabinoids synergizing with radiation and chemosensitizing cells to actually respond, especially CBD. If CBD is in the system, in animal studies, the cancer cells seem to be more responsive to radiation and die easier. That being said, there's a few reports out of Israel showing that immunotherapy combined with cannabis may produce a poorer outcome. And again, we know cannabinoids mess with your immune system. And in general, if you're in good health, it's not an unwanted or a negative thing. But if you are getting immunotherapy, not a good idea to combine. This whole idea behind like the Rick Simpson oil and everything else, it's all anecdotal. That being said, I do treat children who have stage 4 cancer who have come to my office kind of going, we're at the end of the road and there isn't really anything left. At that point, you know, they're looking at a clinical trial, which certainly may not be in their best interest always. And I have had some success with extension of life and even in a few cases, actually eliminating cancer. But again, this is understudied. We have a study from Spain from, I think, 2006, Manuel Guzman's group, that actually put THC directly into the brain through a cannula for glioblastoma multiforme, which if you're familiar with, it's like the tumor that Joe Biden's son died of. And also, I think John McCain had that tumor, very aggressive, very poor prognosis. But there is now reports out of GW Pharmaceutical, who makes Sativex and Epidiolex, that they combine temozolomide, a certain chemo, with CBD and THC in a 1-to-1 ratio for patients with glioblastoma multiforme, and then temozolomide alone, so no cannabis, just the chemo, and the patients who got combination had a longer survival. So there's definitely something there. It is time to start human clinical trials, period. That is what we need. And so for someone who's struggling, there are a handful of practitioners throughout the country who can give you advice on what's safe and what not safe to use.
Excellent, Bonni. To add on, to piggyback to her comments, certainly in my expertise in my area of practice, I deal with a lot of patients who are end of life from a palliative perspective, but also some from a cancer perspective. To comment on the one study about sort of a retrospective study looking at GBM patients. The first one had showed that they were provided intrathecal cannabinoids, and it shrunk the tumor down. However, the first study didn't result in sort of a longer duration of overall survival. However, the subsequent one, it looks more promising. I think GBM is a very devastating disease, and sometimes, you know, I think sometimes patients and families are looking for all sorts of avenues, but I certainly agree that there needs to be further studies. In terms of, I would caution patients who are listening who are have a history of cancer, especially with an intent to try and cure their cancer. So certain types of cancers, there may be certainly reasonable and effective types of chemotherapy agents or novel immunotherapy drugs that can be effective in treating their cancer overall. Now, as Bonni mentioned, that there is evidence that cannabis, particularly with immunotherapy drugs, can interact and decrease the efficacy of those particular agents, not with platinum-based chemos or radiation, but with immunotherapy can reduce the efficacy of that drug to what amount that sort of correlates in terms of disease progression. Likely not a significant deal, but it's important to have that topic with patients in terms of informed discussion and decision making about combining cannabis with particular types of anti-neoplastic drugs. And so certainly I'm very excited to see what the road ahead is regarding cannabis and its future with in terms of cancer treatment overall. So.
Thank you. And I just want to say that there are two people that did ask for a private room with a doctor near the end. So the last 10 minutes, we can break it up a little early and people can have some private talks. So if you do want a private room, let me know soon.
It's like being on OnlyFans.
I know, it sounds weird. I feel weird saying private room, but I don't know how to, any else to say it. Breakout room.
I see, Debbie, one question, which was kind of interesting, but I'd like to hear the other panelists' opinion about this. So can you explain the cannabis pathways related to MTHFR, which kind of looks like—
What's the next question I was going to ask?
Oh, was it? So it looks like, I'm happy to chime in. I don't know a whole lot. I know a little bit about it. It looks like a bad word, but it's not. It's methylene tetrahydrofolate reductase. And essentially from, again, my sort of thought process regarding cannabis and this particular gene mutation that someone may or may not have is that we know that folic acid, particularly vitamin B9, is essential for cell development, particularly with red blood cells. And it is an important sort of cofactor in the metabolism or the metabolic pathway of certain types of amino acids, particularly methionine. So when you have this mutation of this particular gene, it disrupts the metabolism of methionine. And so it happens, from my relatively basic understanding from med school, is that you should have a high elevation of homocysteine levels, which homocysteine itself it has sort of a pro-inflammatory effect, particularly within the cardiovascular system, so within the heart. And so I would assume that when you have this gene mutation, can't metabolize methionine properly, you have high levels of homocysteine, can create some harm to the heart. And so using cannabis, I would suspect a high THC concentrated products, as for the discussion earlier by Dr. Tishler and Dr. Arnsten, is that we know that THC can have sort of or create some sort of adverse cardiac effects, particularly with raising heart rate and so forth. So I would assume that the combination of these two in this type of patient, I would be very hesitant to use a high THC based product. A CBD product or a different type of cannabinoid might be safer, but that's sort of just my 2 cents regarding that.
Thank you. Next question. What are your thoughts about the sensitivity of the DSM's, I don't know if it's CUD or CUD diagnostic criteria? Conversely, what are your thoughts on THC caps?
I think that the DSM-5 has tried hard to get it right. And if we are looking at the general population, by which I really mean the recreational using population, then the diagnostic criteria aren't bad. In fact, I would say the diagnostic criteria are probably fairly good. But what I will say is that they're only as good as the practitioner who is applying them, right? I mean, they're just a set of it's just an algorithm or a set of bullet points for the clinician to recognize a problem use. And one of the things that is an important part of that algorithm is, does the patient endorse or is there evidence for harm in their life? And this becomes a problem, number one, when there are patients who say, look, I'm using cannabis and I'm doing just fine, and so I don't see that there's a problem. If you skip that initial, does the patient endorse having a problem, and simply go down onto the usage patterns, you can certainly misdiagnose somebody as having a use disorder that they don't. And many of the screening tools are simply not effective or validated once we start to talk about medical use. So there is, for example, a screening tool called CUDIT, C-U-D-I-T, and it asks questions like, do you spend a large amount of time thinking about how you're going to get the substance? Well, if you're a patient, of course, you're going to spend a fair amount of time trying to get the substance. It's part of your medical regimen. So there are flaws in this algorithm as we start to apply it to patients as opposed to recreational users. There is, in fact, a CUDIT SF. SF stands for short form, which sort of tried to boil the original set of questions down into something that was more manageable. And in fact, they eliminated a number of the questions that were suspect for medical patients. And so if one were to use a screening tool, the SF is a better approach. I think that THC caps are an interesting idea. I think that they belong in the recreational market, where people are getting, as Dr. Goldstein mentioned, unsupervised approach. In the medical market, I think it's probably reasonable for us to have an array of products, graduated products, just like we do with other pills. Statins, for example, since we've been picking on them this evening, come in, maybe 5, 10, and 20 milligram tablets, and you prescribe what's appropriate for the patient. So I think that, in the medical context, we probably need greater flexibility and the ability to be nuanced in our practice that goes beyond simple caps.
I'd like to just mention Stacy Gruber's work looking at CUD and patients, comparing medical patients and recreational users of cannabis. And I'm not going to go into too much detail, but her work is available and you can read the articles if you just look for Stacy Gruber. I think she spells her first name with an I at the end. But
Yes.
She's done some nice work looking, starting with patients who haven't started medical cannabis yet. And as she says, they're the most studied people in the world. She does MRIs and everything else, all kinds of depression scales and everything else on them, and then follows them as they use medical cannabis. And what she's shown was improved neurocognitive function and ability to get off medication and so on. And no escalation of use that even approaches the diagnosis of CUD. And so I clearly remember her talking about that when she spoke. So I just encourage people to look at that research. As I really liked your slide, Jordan, where you wrote, patients do not equal recreational users. I find that still, no matter where I go and when I talk, people cannot separate these two groups. I think it's very important that we separate. And I'm not saying one is better than the other. Many of my dear friends are recreational users of cannabis. Great. They have good lives and go for it. But I think education is the key. And for those of us that are in the medical world, it is our job to take care of patients who want to use cannabis medically, and then also to kind of put out there the small dangers that come along with recreational use. So things like CHS and other things like during pregnancy and breastfeeding and so on. We should be leading the information on that as well.
Absolutely.
Well, I have a great question that kind of delves into that, what you were saying. But before I do that, I just want to say one fun fact about me was my very first job out of college was actually updating the DSM. I worked for the American Psychological Association, and it was really cool. It was back in 2002, so I don't know what version that was. But the very first word I got to put in there was coprophagia. So if you guys know what that means, it was not a fun word, but I will never forget what that means. So someone wrote, I am on a legislative task force that is examining the potential effects of adult use legalization on our medical cannabis program. We have identified many potential harms, and in parentheses, shortness of products, shutting down our collective grow sites, and a migration away from the patient registry, and fewer educated certifying providers. We've seen this, in Hawaii, they don't even need to go. Sorry, this is me saying, but in Hawaii, they don't even need to go to doctors anymore. So the question is, any suggestions for us to help protect our patients if and when we get adult use legalization? I know I have a lot to say about that, so I want to know what the doctors, how the doctors feel about that and what they want to say.
I'm sorry, can you repeat the question, Deb?
So any suggestions for us to help protect patients if and when adult use legalization comes into a state? What can people do to kind of help protect the medical market?
Well, one thing we did in Massachusetts that I thought was really smart was that it required that dispensaries reserve 30% of their product for medical patients, which was intended and I think reasonably successful at preventing the recreational users from buying up all the store and leaving the patients with nothing. Other than that, I would say here in Massachusetts, the advent of recreational has been an unmitigated disaster for patients. I campaigned in favor of recreational with the thought that if we then established a recreational market for recreational folks, and then we could go back and make a more medical market for medical patients. And so far that hasn't really panned out. And I feel a little duped and I have some regret about having supported recreational, at least in that thought process. So I'm not entirely, I think that the list of harms that you've come up with are spot on, but I do think that it's difficult to protect against those issues once we got that recreational market going. And one last thought before I yield the floor. You'll notice perhaps that I keep saying recreational market and not adult use. I think adult use is another Trojan horse in this industry. It to me implies that either patients aren't adults, which is one thought, or that one should simply roll all of this together and then basically we convince people to go out and DIY their healthcare. And I think that that's a tremendous mistake. So I tend to try to separate. This is the medical market. This is the market for people who are healthy and want to have fun, and people should assort themselves into the appropriate bin. My 2 cents.
I can comment just from being here in Canada, since we had the introduction after medical legalization going back in 2002, and certainly before recreational was legalized in 2018, is that the vast majority of our patients prior to 2018 were certainly of the younger age group who were coming to us seeking medical cannabis, sometimes not always for medical purposes, but what we saw after the legalization in 2018 is that the younger population dropped away. And in fact, we had this uptick in older patients, particularly my patient demographics are mainly patients above the age of 65. So the younger ones left, went to the rec market, to continue perhaps their interest and access to it, despite there being a higher cost associated with it. But we saw here certainly that patients who generally needed it for medical purposes were now able to come in. We saw that they felt more comfortable with asking providers and coming for support. And then certainly there was other aspects to support them in terms of financial assistance with acquiring their products. So I'm curious to see, I don't know exactly how that's turned out in other US states where they have both or not, but I would suspect there might be some sort of split between both populations of cannabis users.
if I could comment, I think that one of the things that I find absolutely abhorrent is that we are taxing medical patients on their medical cannabis. They are not getting taxed on any other medication. And often if they have any form of insurance, there's some benefit to help with the medication, or at least a generic option. And so in California, when we legalized for adult use / recreational, medical was kind of thrown in. I would say because we had a robust medical program that existed for many years before adult use became legal, that medical program, let's say, where you go to a doctor and get paperwork that then you can take to a dispensary, we lost a lot of younger patients, like you saw, Suraj, and kind of the older, and then of course under 21 has to have a letter. So those patients are going to doctors. But to me, it's the taxes that creates a big problem. And if there is not a tax break for medical patients, one, that's shameful. And two, we just have to start thinking about that, because like if you look at Washington State, and Debbie, you probably know better in terms of other states, I know that the medical programs were somewhat decimated by legalization, right? One other thing I would add is that I know that in some states, I think Arizona's one, where you have to have a medical director in the dispensary while they're open. So there is somebody there with medical training who's a healthcare provider, at least with a more advanced degree, giving advice. I have been given advice in a dispensary from a non-physician bud tender, and I've gotten, I mean, I don't even know what to tell you. I mean, the opposite of what is right. So people who are non-medical should not be giving medical advice. I will share with you, I had a patient in my practice. I spent an hour and a half with her. She was she was on the edge with mental illness. Spent an hour and a half, and one sentence by a dispensary worker in a dispensary undid the hour and a half I spent with that patient. And I was furious. And of course I called and gave them, a talking to, and just said, please do not advise my patients. But this is what's happening. And we really have to, and maybe what it is it has to be separated. Recreational, adult use dispensaries are over here, and medical are over here that don't charge taxes.
For those of you, sorry, I was to say, for those of you who don't know, this is one of ACE's big policy pushes for us, because we do believe that medical and adult use or rec are very different, and medical should be prioritized.
Can I just weigh in as well? Because we've done some research in this arena, a couple of different things. So one was an assessment of different states' medical cannabis policies. So, we have 37, I think now, states with medical cannabis programs, and that's 30 different medical cannabis programs. And we ranked them according to how medical they were. So New York State, where I am, and a couple of other states had a very high medicalization score. This has been published for about 6 months now. And many states, the medical programs are identical to the recreational or adult use programs, except that the person needs a medical card. And so, we are lacking federal policy here. And this means that every state will do its own thing. And we're seeing, how that's working out in some other really critical areas right now. The other type of research that we did were it was a dispensary staff survey. So we tried to survey frontline dispensary staff workers in dispensaries all over the country. And this has been published as well. And we asked them a number of questions about how they interact with customers. And, we found that there was, the nuance of what you're talking about, Bonni, people, I wouldn't expect them to know, but I would expect, I would hope that there would be some training so that they would know a little bit about how to counsel people, and that's not what we found at all. Now, the other side of that argument is, well, we don't expect people who work in liquor stores to counsel people about the risk of hepatitis and cirrhosis and, other and neurodegenerative disease. So, but, we really have a terrible gray area going on right now. And we can all idealize in our own minds the best solution, but we have to come up with one, because people are going to dispensaries to treat medical symptoms. I disagree with the dichotomization of people into recreational users and patients. I think many people go to the dispensary and buy cannabis to get better sleep, to treat pain. We published on this too. We did a survey of 1,000 dispensary users, non-medical, identified as recreational users in Colorado. And the vast majority of them, over 3/4, said that the main reasons that they used were to promote better sleep or to treat pain. So I get that this other segment is buying most of the, legal weed, but there are many users in the adult market who are using to treat symptoms. And that's another constituency we can't forget about, because where they're getting their advice is from bud tenders. And, that advice is, I don't think they're lying, but they're telling people what, they learned from the last person they sold to, many cannabis companies are not required to have medical staff on site, or they are. That was part of our medicalization scale. How much training is provided to bud tenders varies tremendously. What sort of quality control in terms of what bud tenders say to people. Are they paid on commission or not? Some of them are. There's really very scary practices out there. And so we have to protect our patients who might think it's okay to go to the adult use market from that, as Bonni was saying.
A survey here in California showed 60% of people going in for the adult use were actually seeking treatment for medical symptoms. So yes, you're right.
Problem is, though, is legislators see the opposite. They think there is no need for medical and that it's only rec.
Well,
so
exactly.
if we can convince them that so many rec and adult use users are actually utilizing the medical market, then they'll understand why we need research and why we need these things, and that it's not just all adult use, one population.
In some ways, it's really sort of sad that we have people who are going to the rec market to treat medical symptoms instead of being able to avail themselves of the guidance of knowledgeable medical professionals. Right? In some ways, I don't care where somebody buys their cannabis. What I care about is that they come to see somebody like Bonni or Julia or Suraj to get that kind of guidance and supervision so that they're doing it safely.
I'd like to weigh in. I know Ask the Doc
waiting patiently.
have an answer that's both ACS and ASA centric and also a business side. So as I mentioned at the top, I am the CEO of a cannabis company that manufactures products and has co-located dispensaries. So from the ASA, ACS point of view, all of you who are listening, the original question, we need you to support us. We are two of the organizations that are prominently trying to advocate for exactly what the doctors are concerned about. And that is to have real regulations that address these issues and formalize the training and the ability for dispensary owners to operate in the manner the doctors want, which is a real prescription. And I mentioned that at the top also. As a dispensary owner, if someone came in with a prescription, here's what the doctor ordered, and I can fill that, I'm perfectly happy. That's perfectly okay with me. And I think we collectively as general public need to get the business owners to understand that that would be acceptable and should be the way it works. On the business side, I'm very interested in insurance subsidies. I think there'd be a bigger pool of people coming to my dispensary if they were getting medical treatment and insurance subsidies. So it may be a selfish reason for it. I'm also a patient, as I mentioned, but I would love to see us ACS formalize how that would work in an estate that's thinking about adding adult use. Make sure that we get to that state, help you, whoever you are in that state, address the change that they're about to make with other medical changes that will improve the program. Perhaps there's some level of federal legalization that's coming that might allow insurance companies to feel differently about it. Doesn't mean interstate commerce, but if banking laws lead to insurance companies being okay with providing that subsidy, and a lot of programs are state-run anyway, then I think we'd make a lot of headway. So I would encourage all of you to support these two organizations, and that is a primary part of our mission.
I just want to also jump in and say ACS does in fact have a course aimed at bud tenders. And we were very careful in the way we designed this to not only help bud tenders understand what we as physicians need from them, but also to help them understand that if we really want to generate a sustainable industry and good medical care, it needs to be a two-way street, right? Just like we have with the pharmacists in the pharmacy system. You know, there are times when I've had my butt saved by a pharmacist calling me up and say, "Hey, doctor, did you really mean to do it this way?" So, you know, there can be that kind of collegial two-way street, but the roles have to be defined and people have to be properly educated so we can have that conversation.
Getting to be about the time to end the conversation. There were two people, as I mentioned, that wanted private rooms, one with Dr. Goldstein, the other with Dr. Tishler. So if you guys could hang around for a minute, I can transfer the people to those rooms. But I just want to thank everyone for being here. There's so many questions we didn't get to, which makes me feel that there is a need for this and that maybe we could do this again in a few months. Yeah, because this is great. Maybe we could actually have the breakout rooms then. We'll figure it out. Don't worry.
That'd be awesome.
I promise you. But thank you all for coming. I've already seen that some people have donated. Thank you so much. I see everything. It's not too late to donate. The link, I think, Carla, if she's still on, if you could post the link to donate, is still up. And that's going to be up for a while. So it's not going to end after this. Thank you. Do we want to do any last final thoughts or a final question? Or do we want to just kind of end it here, because there are a few more questions. But
I just want to say what a treat it was listening to my colleagues. I am, you know, not sorry that we didn't have the breakout rooms, because it was great to hear you all.
I second that feeling. This was a great experience for me, and thank you guys.
And I do want to say, so Americans for Safe Access, we have a conference coming up. It's called our 10th annual National Medical Cannabis Unity Conference in December. So save the date, December 12th through 14th. I would like to invite all the doctors to attend that conference. And this has really inspired me to do a Q&A at that conference. So I would love to do a doctor Q&A at that conference, at our conference, and look at our website for more information to that.
And ACS is a partner in that conference as well. We're very excited to support.
Thank you. Yes, you guys are.
Let me, I'm so sorry. We're all tired. There's one question in there asking for the references for the medical cannabis studies I was talking about. I could send them to you, but if you have access to PubMed, if you just look for me, Arnsten J, you'll find them. There isn't another Arnsten J on there. But that would be my recommendation.
I just wanted to make one comment and just say thank you to all the listeners for giving us the opportunity to meet with you today, ask amazing questions. I was not expecting these types of questions, but I think they were certainly important. And this just goes to furthering, you know, the support and the need to advocate about safe access to cannabis for patients and others. So thank you again for coming in and spending, I think it was like the last 2 hours, so hearing us mumble and talk. So thank you all to the listeners.
Thank you. And Amanda and Samuel, if you guys want to stay on for a minute, I can put you in a room with Dr. Tishler and Dr. Goldstein, if you guys are still there. So thank you all for coming today, and feel free to reach out to us if you need anything, and we'll let you know about the next webinar. Okay.
You all.
Thanks, y'all.
Bye.